Finals SAQ68, Acute Pancreatitis. A. List the common causes of acute pancreatitis. A useful mnemonic to help remember causes of acute pancreatitis is bad times, B for biliary gallstones, parasites, or malignancy. Biliary gallstones consist of 40 to 70% of cases. Examples of malignancy causing biliary obstruction includes head of pancreas, periampullary primary, or metastasis from breast, kidney, stomach, ovaries, or lung. A for alcohol, 25 to 35% of cases, or autoimmune cause such as vasculitis or sclerosing cholangitis. D stands for drugs. Examples of drugs implicated in acute pancreatitis includes ACE inhibitors, furosemide, tetracycline, corticosteroids, paracetamol, etc. T stands for trauma or toxins. I stands for idiopathic, which occurs in 20% of cases. Ischemic, infectious, such as due to HIV, CMV, Mycoplasma or Legionella, or inherited genetic mutations, whereby family history of pancreatitis may be present. M stands for metabolic, such as hyperlipidemia or hypercalcemia. E stands for ERCP and S stands for smoking. B. How is acute pancreatitis diagnosed? Diagnosis is based on the revised Atlanta classification 2013, with two of the following three features present: abdominal pain consistent with acute pancreatitis, serum lipase or amylase at least 3 times greater than upper limit of normal, and characteristic radiological findings such as that found in CT scan. Describe the classification of severity of acute pancreatitis. Based on the revised Atlanta classification, mild acute pancreatitis has no organ failure or local or systemic complications. Moderately severe acute pancreatitis has organ failure that resolves within 48 hours and/or local or systemic complications without persistent organ failure. Examples of local complications include pancreatic necrosis or pseudocyst formation. Severe acute pancreatitis has organ failure persisting for more than 48 hours. Examples of organ failure include systemic shock, hypoxemia, renal failure, and GI hemorrhage. Other classification methods, such as based on Apache-2 system, CT severity index, modified CT severity index, bedside index of severity in acute pancreatitis, and Ranson score, has various limitations such as low sensitivity or specificity, complexity of scoring, and inability to obtain final score until 48 hours after admission. D. What are the specific principles of managing severe acute pancreatitis in a critical care environment? Airway and respiratory, provide supplemental oxygen and keep oxygen saturations above 95%. NIV, intubation, and positive pressure ventilation may be needed for ARDS, diaphragmatic splinting due to pain, intra-abdominal edema or fluid collections, and pleural effusion. Cardiovascular, targeted fluid therapy with intra-arterial blood pressure and cardiac output monitoring. Fluid losses may be due to reduced oral intake, vomiting, extravasation, or hypoalbuminemia. Adequate volume repletion in the form of isotonic crystalloid such as lactated ringers aims to restore perfusion to the pancreatic microcirculation and prevent further cellular death. Example of regime is 20 ml per kg over 60 to 90 minutes, followed with an infusion rate of up to 250 ml per hour for the next 24 to 48 hours to maintain MAP of 65 mmHg or more and urine output of more than 0.5 ml per kg per hour. After initial aggressive volume resuscitation, infusion rate of IV fluids should be reduced and guided by various clinical parameters, as aggressive volume infusion promotes edema, which can aggravate conditions such as ARDS and increases the risk of abdominal compartment syndrome. Inotropic or vasopressor support as required. There are no official recommendations regarding vasopressor therapy in severe pancreatitis, but noradrenaline is an appropriate choice. All vasoconstrictor drugs can reduce splanchnic blood flow, especially adrenaline, hence careful titration of infusion rates is advised. Neurological, sedation for invasive ventilation, and pain control. Consider organ dysfunctions in evaluating choices of analgesics. blood glucose management, aiming for blood sugar of 6 to 10 millimoles per liter. Gastrointestinal, early enteral nutrition if no contraindications. Compared with parenteral nutrition, EN is associated with less infections, multi-organ failure, lower mortality and lower cost. Parenteral nutrition if intolerant of enteric feed, stress ulcer prophylaxis, and monitoring of abdominal compartment syndrome and its treatment. ACS is reported in about 50% of patients with severe pancreatitis and can cause oliguric renal failure. Intra-abdominal pressure may be measured using a specialized bladder catheter in a decompressed urinary bladder in the supine position at the end of expiration with no abdominal muscle contractions, and the pressure transducer is zeroed at the mid-axillary line. Normal IAP is 5 to 7 mmHg. Intra-abdominal hypertension is IAP more than 12 mmHg, and ACS IAP more than 20 mmHg with acute organ dysfunction. Treatment of ACS is sedation, avoid elevation of head more than 20 degrees above horizontal line, avoid positive fluid balance, treatment of underlying cause, consider decompression, drainage or surgery, and maintain abdominal perfusion pressure of more than 60 mmHg, where APP equals MAP minus IAP. Hematology, thromboprophylaxis with thromboembolic deterrent stockings or pneumatic compression devices. Consider low molecular weight heparin if no evidence of hemorrhage, and unfractionated heparin if acute kidney injury is present. The need for pharmacological thromboprophylaxis must be balanced against the risk of massive hemorrhage in acute severe pancreatitis due to pseudoaneurysm development. Infection or immune. Antimicrobial agents if infected pancreatic necrosis is suspected or other associated sepsis is present. Prophylactic antibiotics are no longer recommended for sterile pancreatic necrosis in the absence of systemic infection. CT scan with IV contrast can demonstrate air bubbles in pancreatic fluid collections, which can confirm the diagnosis of infected pancreatic necrosis. Antibiotics are also used in systemic complications such as pneumonia or cholangitis. Ensure the causative agent is sought, such as by radiologically guided aspiration of pancreatic or peripancreatic tissue. Treatment should target gram-negative and fungal infection. Carbapenems are the preferred agent as they have high pancreatic penetration and broad-spectrum coverage. Quinolones, metronidazole, and high-dose cephalosporins are alternatives in carbapenem allergy. Renal. Minimize risk of acute kidney injury by optimizing fluid status with cardiac output monitoring and avoiding nephrotoxins. Target urine output of more than 0.5 ml per kg per hour. Renal replacement therapy may be required. Correct electrolyte abnormalities. Surgical input. Pancreatic necrosis. Asymptomatic pancreatic necrosis does not mandate intervention and will likely resolve over time. Long-term studies demonstrate lower mortality and complete resolution of infected necrosis with antibiotics alone. Surgical debridement or endoscopic drainage with necrosectomy is now reserved for patients failing to respond to antibiotics, with expert panels recommending delaying necrosectomy for at least 4 weeks in persistently symptomatic patients while administering antibiotics to allow for the necrosis to organize. Minimally invasive options for necrosectomy are becoming increasingly favored, with endoscopic approach and percutaneous approach as available options. Acute pancreatitis secondary to gallstones may require ERCP with endoscopic sphincterotomy. Studies have found a significant benefit in performing ERCP only in the setting of biliary sepsis or retained common bile duct stones. Studies have supported the notion that patients with mild gallstone pancreatitis should undergo cholecystectomy at the time of their index hospitalization to avoid development of recurrent pancreatitis. In patients with severe pancreatitis, cholecystectomy is typically delayed until resolution of acute illness and inflammation. Treat associated or causative conditions of acute pancreatitis. Overall, 53.6% pass rate. Additional Q&A. What is acute pancreatitis? This is an inflammatory condition of the pancreas caused by local release of pancreatic enzymes in response to a recent acinar injury. Types includes edematous pancreatitis and necrotizing pancreatitis. The edematous form is the most common form, characterized by inflammatory infiltration of the pancreas without involvement of other organs. Clinical presentation is usually a self-limited period of abdominal pain, nausea and vomiting, with a low mortality of less than 2%. Management rarely requires ICU level care. Necrotizing pancreatitis occurs in 10 to 15% of cases. It is characterized by areas of necrotic destruction of the pancreas and is usually accompanied with progressive systemic inflammation and injury of extrapancreatic sites such as lungs, kidneys, and the circulatory system. Mortality can be as high as 40%, and management requires ICU level care. What are the presenting signs and symptoms of acute pancreatitis? Possible symptoms include constant abdominal pain of sudden onset, classically located at the epigastrium or left upper quadrant, with radiation through to the back, chest, or flanks. Nausea and vomiting, anorexia, diarrhea may occur. Symptoms of complication may be present, such as dyspnea, hematemesis, melena, and muscle spasms. Signs include fever, tachycardia, tachypnea, hypotension, jaundice, abdominal tenderness, muscle guarding and distension, bibasal lung rales and reduced air entry, Gray Turner sign, Cullen sign, erythematous skin nodules, and puncture retinopathy. Are amylase and/or lipase measurements helpful in the diagnosis of acute pancreatitis? Amylase is an enzyme that cleaves starch into smaller polysaccharides. Principal sources of amylase includes pancreas, salivary glands, and fallopian tubes. Serum amylase rises 6 to 12 hours after the onset of acute pancreatitis and returns to normal in 3 to 5 days. An increase in serum amylase to 3 times the upper limit of normal has a high sensitivity, more than 90%, but low specificity, as low as 70%, in the diagnosis of acute pancreatitis. Elevated amylase levels are seen with conditions such as bowel infarction, renal failure, perforated peptic ulcer, trauma to salivary glands, and macroamylasemia. Lipase is an enzyme that hydrolyzes triglycerides to form glycerol and free fatty acids. Principal sources of lipase include the tongue, pancreas, liver, intestines, and circulating lipoproteins. Serum lipase is more specific and more sensitive compared to amylase in diagnosing acute pancreatitis, with a sensitivity and specificity of 80 to 100%. It begins to rise 4 to 8 hours after the onset of acute pancreatitis, and levels remain elevated for 8 to 14 days. Unlike amylase, non-pancreatic conditions rarely raise serum lipase levels high enough to overlap with the levels seen in acute pancreatitis. No correlation exists between serum lipase levels with the severity of pancreatitis. Adding serum amylase does not increase diagnostic accuracy. There is no recommendation to trend lipase levels. What is the role of imaging in the diagnosis of acute pancreatitis? Abdominal ultrasound should be performed in all patients presenting with acute pancreatitis. It is non-invasive, relatively inexpensive, widely available, and can detect the presence of gallstone-related diseases and other biliary abnormalities. Imaging beyond an initial abdominal ultrasound on presentation is often reserved for patients failing to improve clinically within the first 48 to 72 hours. CT with oral or IV contrast has high sensitivity and specificity in diagnosing acute pancreatitis and its complications. Possible findings include evidence of inflammation, peripancreatic or intrapancreatic fluid collections, pancreatic perfusion abnormalities, and presence or extent of pancreatic necrosis. Patients with continued abdominal pain, fever, or inability to initiate oral feeding should be sent for CT scan with IV contrast. IV contrast help to distinguish between edematous and necrotizing pancreatitis. MRI is a reasonable option in patients who cannot receive contrast for CT scan, with good correlation between MRCP with CT scan in the evaluation of acute pancreatitis. MRCP also has added benefit in better defining pancreatic and biliary ductal systems in suspected biliary pancreatitis. How do you determine the prognosis of acute pancreatitis? The prognosis can be determined with various scoring systems such as the modified Ranson criteria, with number of criteria met of 2 or less, predicted mortality 0.9%, number of criteria 3 to 4, predicted mortality 16%, number of criteria 5 to 6, predicted mortality 40%, number of criteria met 7 to 8, predicted mortality 100%. Other options for prognosticating acute pancreatitis includes bedside index of severity in acute pancreatitis score, modified CT severity index, and Apache 2. How should patients with pancreatitis be fed? Enteral feeding is the preferred method. It helps maintain the intestinal mucosal barrier and prevents bacterial translocation, which may be a major source of infection. No strong evidence exists that nasojejunal feeding is advantageous over nasogastric feeding. It is not known if low continuous rate compared with bolus feeding is optimal. Checking gastric residual volume is not usually helpful and is discouraged. Most experts would agree immediate feeding is safe and well tolerated in patients with mild acute pancreatitis without nausea, vomiting, or ileus. Parenteral feeding should be avoided in patients with acute pancreatitis due to higher rates of infection and line-related complications. A recent meta-analysis found decrease in infection complications, organ failure, and mortality in patients who were enterally fed compared with those provided with parenteral nutrition. What are pancreatic pseudocysts and how should they be managed? Pancreatic pseudocysts are localized fluid collections surrounded by a wall of fibrous tissue that is not lined by epithelium. The fluid is often rich in amylase and other pancreatic enzymes. Pseudocysts can form as a result of pancreatic necrosis during an episode of pancreatitis, or because pancreatic duct disruption due to stenosis, calculus, or trauma. The patient may be asymptomatic or present with pain, bleeding, infection, or rupture. Other complications include gastric outlet or biliary obstruction, and thrombosis of splenic or portal veins with development of gastric varices. Diagnosis is via CT scan. Management options include no intervention for asymptomatic pseudocysts. Indications for drainage are limited to complications from the cyst, such as biliary or luminal obstruction and spontaneous infection of the cyst. Surgical, percutaneous, and endoscopic approaches have all been used to drain pancreatic pseudocysts. These are my references. Thank you.